Right. Welcome everyone to this webinar of Scan Academy in collaboration with our friends at the Society of Maternal-Fetal Medicine, the SMFM in the USA. I'd like to welcome you all to this exciting program today, and I wish you a good morning, a good afternoon, or good evening, depending on where you are around the world. We've got over 1,700 people registered today on this webinar. And we're really happy to have fantastic, distinguished guests with us today. My name's Aris Papageorgiou. I'm a professor at the University of Oxford. I'll be co-chairing today with Joey Biggio, who's in New Orleans at the moment. I'd like to, first of all, introduce Joey. He's going to give us a few words about one of the reasons that we're having this webinar. And one of the reasons we're having this webinar is that in October, in Rome, there will be the first SMFM meeting outside the USA. Now, there's lots of good information in that short statement. Rome, which is one of the most beautiful places you can visit. October, which is one of the most beautiful times of the year that you can visit it. And SMFM, which is one of the best meetings that you can attend. I can honestly attest to that, having attended many of these indeed. So Joey, welcome, and I hope you can give us a few words. I'll quickly introduce you while you get your slides up. Joey Joseph Biggio graduated from New Orleans and got his degree of medicine at the University of Alabama in Birmingham, completed his residency in OBGYN and a fellowship in maternal-fetal medicine, and also in clinical genetics at the University of Alabama in Birmingham. And really importantly, Joey doesn't only specialize in high-risk pregnancies, but he's got a particular interest in healthcare quality and healthcare safety. So he's actively working to improve obstetric care through improving standards. And in fact, he has a master's in healthcare quality and safety. Joey, you've got so many accolades, but I just wanted to highlight one because I do work a little bit with the March of Dimes. And I know that you received some time ago the March of Dimes Award for Best Research in Prematurity, and I can only congratulate you on that. This is a fantastic achievement. So, Joey, thanks very much for telling us a little bit about the Rome Congress. Really importantly, go into the Joey doesn't only specialize in hearing from Tullio, Mar, and Joanne on some of the advances in maternal-fetal medicine. Thank you.
Well, Aris, thank you so much, and thank you for the invitation to help co-sponsor this webinar today. So, like Aris was saying, we are having our first SMFM meeting located outside of the U.S. It is in Rome. It's almost in October. It's at the very last week of September. So if you extend for a couple days, you can spend some time in Rome in the beginning of October too. But it's September 25th through the 28th. There's information at, if you go to the smfm.org website, there's lots of information. And we have it set up as a 3.5-day Congress. The first day is set up as pre-Congress courses. And really one of the things we're emphasizing in this is the sort of the global nature of what we're facing in obstetric care and trying to focus on both maternal and fetal challenges, morbidities. And we really are trying to cover the gamut in terms of the courses that are offered. And you can see there's courses on the great obstetric syndromes, there's a fetal echo simulation course, maternal critical care, and then a course regarding the placenta accreta spectrum. On Thursday, our opening plenary session is something that our planning committee is particularly excited about because of the people that we have coming to really open this historic session for us. Dr. Roberto Romero from the NICHD will come and talk about all the work he has done over the course of his career, as well as what is continuing to evolve in the diagnosis and treatment of intraamniotic inflammation. Professor Delia Numba from University of Sheffield is talking about social determinants and the disparities on maternal and fetal health outcomes. Dr. Oladapo from the WHO is talking about the maternal health crisis and the work that the WHO is doing, especially with regard to postpartum hemorrhage. Professor Thalaganthan is speaking with regard to hypertensive disease and their impacts on pregnancy. And then Professor Nicolaides is coming to speak about all the work he has done and has helped orchestrate with regards to prediction and prevention of preeclampsia. So, we felt particularly excited to offer this lineup of speakers. The remainder of the meeting is then set up as oral concurrent sessions that will happen Thursday afternoon, Friday morning, Friday afternoon, and Saturday morning, where we have invited talks, as well as within each session, 4 to 5 oral platform research presentations. And then we have, over the course of Thursday and Friday, 4 poster sessions with oral poster platform presentations in each session as well. Overall, there's over 450 abstracts are scheduled to be presented. And then we're closing the meeting on Saturday with another plenary session with a debate by Dr. Cynthia Jamfi, who is the SMFM president this year, but also was the PI for the NICHD ALPS study. So she'll be debating Dr. Fabio Facchinetti from Italy, as well as Dr. Cornelli, who's a neonatologist, with regards to the approach to late preterm steroids. And then Dr. Vincenzo Bergella, and Vincenzo has been one of the driving forces behind having this first international meeting, and certainly has helped us get the meeting in Rome. And Vincenzo is going to close the meeting out with a discussion about, the evolution of where has obstetric care gone in the last few years and where is it going in the future, especially as we talk about technology, AI, and all of those things. So we're very excited to be hosting this first international SMFM meeting. We hope there will be more in the future. Right now, as of today, we have almost 600 registrants for the meeting, and hope that some of you will be joining us there in Rome. So I'm going to now introduce our first speaker for this morning's session, and this is Professor Tullio Ghi. Tullio was born in Italy in 1973. He's currently a full professor of obstetrics and gynecology, director of the residency in obstetrics and gynecology, and president of the midwifery school at the University of Parma. He is also the head of obstetrics and gynecology unit at the maternity hospital there as well. Starting later this year, he will serve as full professor of obstetrics and gynecology at the Catholic University and chairman of the obstetrics unit at the Gemelli Hospital of Rome. His main fields of research are on obstetrics, ultrasound in labor, fetal-maternal medicine, and prenatal diagnosis of congenital anomalies. He is also a member of the scientific committee of the International Society of Ultrasound in Obstetrics and Gynecology. So we're happy that he can join us here today, and he will, Professor Ghi will also be one of the speakers in Rome as well. So thank you so much for being here.
Thanks, Joseph. Thanks, Harris. It's a great honor for me to be with you today. Please, can you allow me to share the screen? Okay, thank you.
So Tullio, when we come to Rome, you will be already in your position in the University of Rome. So this is great news for Rome and for you and for all of us to have an ally like that at one of the biggest units in Italy. And I'd like to take a moment just to congratulate you on what is a really fantastic appointment, and congratulate the unit actually for hiring someone like you.
Thanks, Harris. You are a friend. So happy to be with you today. So I will try to cover briefly why we should consider to implement the use of ultrasound in labor ward. We have always assessed the critical parameters to evaluate labor progression by digital examination. We know that we need to be confident in assessing the fetal head level in birth canal, position, and attitude, because thanks to these parameters, we can take the right decision whenever we are in doubt regarding the labor progression. But as you all know, in the last few years, there has been the attempt by some research group and then on a regular clinical basis in some setting to use ultrasound or to introduce ultrasound in labor ward in order to confirm the clinical finding, to make them more objective in order to refine the clinical assessment of the patient. This has represented a true revolution for a very semiotic art like obstetrics. One of the parameters we are used to assess in labor ward is the assessment of the fetal head position. So the position of occiput, based on the fact that it is just behind the pubis or is towards the sacrum, is defined anterior or posterior. But there are some observational studies that first of all, almost 20 years ago, have shown that just before an instrumental vaginal delivery, the clinician is not able to be correct in assessing the fetal head position, is wrong in 25% of the cases, and maybe even more when the position of the occiput is lateral or posterior. So this is part of several other observations, has led some clinicians to suggest the use of transabdominal ultrasound in labor ward to check the fetal head position. It's quite easy to place the probe on maternal abdomen and to check which is the fetal part just behind the pubis. If we see the cervical spine, this means that it's occiput anterior position, while when we see the two orbits, that means that the fetus is in occiput posterior position. How it works, ultrasound compare with the traditional obstetrics in the assessment of fetal head position in labor, and particularly before operative vaginal delivery. We know that we have to be extremely sure of the fetal head position before placing a vacuum or forceps. There have been a couple of randomized controlled trials. The first was conducted in Ireland. More or less 257 patients were allocated with vaginal examination before vacuum or forceps, while the other half of the patients were allocated to having a vaginal examination plus transabdominal ultrasound to assess the fetal head position. In the group that received standard care, only vaginal examination, the incidence of wrong assessment of fetal head position was much higher, 20% of the cases, while this was much lower when also ultrasound was used. In Italy, I had the privilege to lead this multicentric study, randomized study, which has a similar design. We allocated half of the women to have vaginal examination only, while the other half of the women had vaginal examination plus transabdominal ultrasound, and we have shown that the rate of incorrect diagnosis of occiput position was much higher when only vaginal examination was used. Regarding the assessment of the fetal head station, we have been taught since we start our residency that we should compare the leading part of the skull with the virtual plane passing through the ischial spines, and based on this distance, we should describe this is level 0, level of the ischial spine, minus some centimeters, plus some centimeters if it is above or below this plane, respectively. It's very important to assess properly the head birth canal, because based on that, we know if we are allowed to proceed or not with the instrumental vaginal delivery. This is the ECOG classification that shows that whenever the fetal head is not engaged, is higher than 0, the ischial spine level, any attempt of operative vaginal delivery should be contraindicated, while the difficulty of the instrumental vaginal delivery becomes lower whenever the fetal head is lower in the birth canal. So mid cavity is feasible as relatively difficult operative vaginal delivery. It becomes easier if the fetal head is low in the birth canal, plus 2 centimeters, or at the outlet. Well, we do not have plenty of data regarding the accuracy of clinical assessment of the fetal head station. This is a study that was conducted a few years ago that has shown, interestingly, that if we take different researchers and ask them to describe the fetal head level in the birth canal, the degree of agreement of concordance among the different clinicians, even if they are relatively expert, is definitely poor. In the best scenario, they agree in the 50% of the cases, where there are some stations where the agreement is in the range of 20-22%. You can see at +1 agreement, 22% of the cases. And this is inconceivable because we are taking a clinical decision that may impact on the health of the mother or of the baby. How can we assess at ultrasound the fetal head level in the birth canal? We can use a different approach compared with the one we are used with ultrasound. Is transperineal ultrasound. You can see this is a video clip on a mannequin. We can place the probe on the fourchette, and we can use an axial or transverse approach, or we can change the orientation of the probe with a vertical or sagittal approach. Depending on the scanning plane, we can obtain two different parameters among those who have been suggested, which have been suggested. One is the distance between the skull and the skin of the perineum. It's called the head perineum distance. Was proposed by Professor Torben Egebo from Norway, and this is the way how we measure this distance. And the other parameter with the vertical or axial approach of the probe on the perineum is the angle of progression. It was first introduced by Dr. Barbera. He was working in Denver with Professor Hobbins. And this is the way how we measure this angle, a line that is crossing the pubic bone, and second line starting from the inferior margin of the pubis, which is tangential to the lower part of the skull. The wider is this angle, the lower is the head in the birth canal. This is a picture obtained at transperineal ultrasound to measure the angle of progression. This is this angle. Well, differently from what we have for clinical examination of the fetal head level in birth canal, the concordance of different operators, the agreement of different operators in measuring transperineally the angle of progression or the head perineum distance is extremely high. So excellent inter-observer agreement, much higher compared with the clinical examination of the fetal head level. So based on what I've just said, we may somehow agree on the fact that digital findings can be subjective and inaccurate, especially in labor in the second stage due to the presence of molding and caput, and this may lead to wrong diagnosis of fetal head position and station, while introducing ultrasound in labor ward may support the clinician in making more objective and more accurate the assessment of position and station, and also in diagnosing some malposition or malpresentation. There are several good reasons to add intrapartum care, to add intrapartum ultrasound to standard care. I would just, for a constraint of time, I will focus on what I feel is the most important one. Thanks to the use of ultrasound, we may improve our prediction on the feasibility and the outcome of instrumental vaginal delivery. This is a study conducted in France almost 8 years ago. More than 230 women were submitted to ultrasound, transperineal ultrasound, just before vacuum. The authors have measured the angle of progression. In this series, they experienced 12% cases failure. They find more than 3 pop-off for procedure lasting more than 20 minutes. Interestingly, comparing those cases where they failed vacuum extraction compared with the successful extraction, the clinical station was not different between the two groups, while what was significantly different was the sonographic station, in the sense that the angle of progression was wider. That means the fetal head was actually lower in the case that had a successful vacuum extraction. And this is somehow testifying that ultrasound makes better the prediction of the outcome of instrumental vaginal delivery compared with clinical examination. Similar results from this study, again conducted in France. The author have enrolled more patients, more than 650, and they had 18% of what they define as difficult vaginal extraction. In this case, the author have used as a sonographic parameter the head perineum distance. As you see from this table, you can see that was the strongest predictor of the difficult instrumental vaginal delivery, much stronger than the other parameters, while the clinical station did not enter the model, so was not significantly associated with the outcome of the procedure. Actually, if we compare the ROC curve, the accuracy of ultrasound compared with digital examination in predicting the difficulty of the instrumental vaginal extraction, you see that the steepness of the ultrasound assessment was greater compared with the digital examination. Recently, I was part of this multi-centric study conducted with France. We have enrolled almost 1,000 of women undergoing to a mid-cavity vacuum extraction. You see, in this case, we expect a higher rate of failure, was 25% of cases. And interestingly, again, the sonographic parameters of the station, the head perineum distance, was among the predictors of outcome, while the clinical station did not enter the model. So some authors, in particular from the Charité Hospital of Berlin, they proposed also to use ultrasound while we are placing the blade of the forceps in case of rotational forceps like the Killand procedure. So these are cases that are showing that we can really take advantage, take benefit from the use of ultrasound before doing the procedure or during the procedure. There was a randomized control trial that was published 4 years ago from the group of Diogo. They have enrolled almost 230 women and shown that actually introducing ultrasound before vacuum or forceps with the aim of assessing the fetal head position and station did not produce a benefit for the mother, for the baby, and did not reduce the rate of cesarean. So apparently it seems that the result of the observational study regarding the usefulness of ultrasound in predicting the outcome of instrumental vaginal delivery has been denied by this only randomized control trial. But if we look critically at the paper from Portugal, we notice that the number of subjects that have been enrolled is extremely low. There are just 222 women, and this is definitely not enough if we want to show a clinical benefit of ultrasound in improving the outcome of the procedure. We have to enroll at least 1,300 women in order to prove that there is somehow a benefit or to deny a benefit of ultrasound compared with clinical examination. Based on this awareness, ISWOG has recently produced some guidelines endorsing the use of ultrasound in labor, particularly before considering or performing instrumental vaginal delivery, recommending the assessment of the fetal head position and station. And very recently, also the Royal College, which is a very conservative institution, has decided to endorse the role of ultrasound in assessing the fetal head position before assisted vaginal birth, especially if the clinician is uncertain following clinical examination. But if we go back to the data that I've showed, the rate of error in the study is in the range of 20%. So we can say that it is always a certain degree of uncertainty of the clinician. So based on that, we could somehow conclude ultrasound should be used before vacuum or forceps to confirm the fetal head position, and possibly, although this is still a matter of investigation, also to assess the fetal head station. Thanks for your attention.
Well, this is fantastic, Tullio. Thank you so much for your brilliant overview of that. And I'd love if the faculty can join us for a brief Q&A. Tullio, for those of you who are online, Tullio is one of the most beautiful places in Italy at the moment on his family holiday and has taken time out to join us. So first of all, thank you for that, Tullio. Joey, I know that you've worked so hard on safety, quality in obstetrics and fetal medicine. And you know, a lot of what Tullio has been talking about really speaks to that, you know, failed instrumental births, due to malpositions, or rather not correctly identifying the position of the baby, deflection or asynclitism, etc., or indeed the fact that the head may be too high. Is this something that is getting traction in the USA? And I ask this as a clinician. I'm convinced of the value of this, but what I also observe, Tullio, and this may be just my observation, is I haven't seen wide-scale adoption of this, and I don't know where the gap is between the evidence and the adoption on the one hand and the adoption on the other. So I don't know, Joey, what your experience is in the USA.
So I think this is fascinating work, and I think it really does emphasize the potential to utilize advancing technologies to improve what we do. It has not been widely adopted in the US, and I think part of it is because operative vaginal deliveries have decreased so astronomically in the US over the last few decades. The number of obstetricians who are skilled and trained in forceps deliveries especially has gone down dramatically. And so really many obstetricians are trained in only the vacuum and are comfortable using only the vacuum. And I think, having more people understand this work, certainly could help the U.S. combat some of the challenges we face with our cesarean delivery rate and the complications in operative vaginal deliveries that have led to the lawsuits, the concerns about malpractice, and all of those things that got us into the situation we're in the U.S.
Thank you, Joey. Tullio, I don't know if you have any observations around this gap between evidence and practice, if you like.
Well, I think that you have touched the Achilles heel. I mean, we have a relatively solid awareness that when we do ultrasound, for those who are on the floor, I mean, I've always been on the floor, so I deliver the baby. Whenever I'm in doubt using ultrasound, I feel more confident in taking my decision, and whoever actually is in the practice of doing operative delivery, they are in labor wards, they really appreciate the value coming from ultrasound. It is difficult to demonstrate with a proper well-designed study with a randomized controlled trial that this is beneficial, because the number of subjects that we need to enroll is huge. It's more or less the same story of CTG, Aris, I think. I mean, it's something that we cannot live without, but all the data coming from the study, for some reason, have denied the value of CTG in fetal surveillance in labor. I think that in our setting in Europe, especially, there has been a very quick uptake on ultrasound in labor, and especially the relatively young generation is using ultrasound progressively more. And also, I think that the message coming from the Royal College is very important, because the Royal College is a wide coverage. It's not UK, but it's all the UK-related countries. In the US, unfortunately, as Joseph was saying, there has not been such a great interest. There are some people that are really supporting this. Professor Romero, I'm always discussing this. Is one of those who believes a lot in the use of ultrasound in labor, but there has been some maybe people are waiting for a stronger evidence. We are at the moment conducting a huge study with thousands of people enrolled that will not be actually a randomized control trial, because believe me, randomizing patients at the time of a vacuum is not easy at all, but it will be a sort of propensity score matching, including all the countries doing operative vaginal delivery. And I think that this can give a good proxy of a robust demonstration that ultrasound make operative vaginal delivery safer and more efficient.
Well, Tullio, we really look forward to those data, and we hope that you will submit them to the SMFM next year. The deadline is on Monday. I suspect we may see them in 26 as opposed to 2025. I mean, I think there's different levels of this ultrasound in labor, isn't there? There's a kind of a basic thing, which is I'm about to go and do an instrumental birth, and I put the probe on to see whether I see the eyes or the back of the head. You know, is the baby OP or OA? And then there's a sort of slightly more complicated stuff of angles and this and that and the other, and maybe the way in is to start with a simpler thing, which is determining the position of the baby before doing an instrumental birth. And there, given the failure rates of 15-20%, actually the sample size you might need to demonstrate effectiveness is not so high, because the failure rate should be it is very significant. We've got Elena on the on our Zoom call today. Elena's a trainee with us at Oxford, and for those of you who don't live in the UK, you won't know, but Oxford is one of the paragons of instrumental birth, still routinely carrying out Keelan's forceps and things that in many other units are kind of not used so much. So I'd love to hear from Elena what her experience is on the ground in a unit which delivers a lot of babies every day and where instrumental births are done. Is that something that's starting to have some effect in the UK, or is the picture similar to the US?
So from my personal experience, I've been training in Italy, and I'm doing my residency in Rome, in Sapienza University of Rome. And we actually use intrapartum sonography to pre-plan and assess the operative vaginal delivery. We mostly use vacuum. So forceps is something anecdotal in my labor and delivery suite, but sometimes I manage to see some forceps application. And what is really different from my setting in Italy compared to this setting in the UK is that I participated in a lot of forceps delivery. So basically the intrapartum sonography used to pre-plan a forceps is not that different compared to the vacuum. I think that the most important difference is how you feel confident in applying the vacuum compared to the forceps. But it was really surprising for me to see how they pre-plan also a rotational forceps, and I think.
Oh, we've lost Elena. Well, listen, we're going to move on.
Can I let me say just
yes.
one quick thing. People do not have to think that doing intrapartum ultrasound will make people lose their clinical skills. This is a very widely recognized experience. If you do intrapartum ultrasound, you will reinforce your ability to be precise with your clinical, because you will correlate the ultrasound finding with the sensation that you feel with your digital examination. So this is a very important message to be given.
Tullio, thank you so much. Joanne, please.
Yeah, I just want to say I totally agree with you. I mean, at Mount Sinai, where I am in New York City, we do a lot of forceps deliveries, and we have some of the old timers that think, and I think everybody should have a scan to really during labor to assess fetal position, because it really helps you plan and especially before an operative delivery. But we have some of the old timers who think, oh my goodness, why do you need an ultrasound? But I agree with you. It totally, for the residents, it teaches them that they can correlate the ultrasound exam with their clinical exam. So 100% agree with you.
Joanne, and I agree with your old timers, but at the same time, the data are what the data show. Dublin, one of the best obstetric units, I guarantee you it's brilliant. Deirdre Murphy's study showing 20% of cases having the application of the instrument not correctly done within the arm without the ultrasound. So, we're not talking about some sort of fairy unit. This is, very classic obstetrically trained units with very experienced people. This is what happens on the ground. And your old timers, while they may be very confident, they don't run the labor ward overnight. It's the residents who run the labor ward overnight. And that's a really important aspect. We've got a couple of questions online, so I hope, Tullio, you'll be able to bear with me. But I wanted to just introduce Prashant, who's jumped on the call. Prashant is a fantastic colleague and friend in India. Thank you so much, Prashant. And we have 1,700 people on the webinar, from Albania and Argentina all the way to Zambia and Zimbabwe. And number one, as usual, is India, with over 250 delegates right now. Number two is the Philippines, and we have lots of other countries represented as well, including the UK. Tullio, a question then from Razia in Tanzania. And this is important because in urban settings and LMICs, in a lot of the underserved regions, cesarean sections are really taking off, because there's an appreciation of the value and the possibility of instrumental births. So Razia says, at what stage of labor can the ultrasound be reliably used to detect the position of the fetal head? Because the fetal head position changes during labor. At what point would you do that if you don't have someone on the ground who's constantly there?
My suggestion is to do ultrasound to assess fetal head position in two possible scenarios. One is in the second stage, when you have to take a clinical decision on how to expedite delivery. And the second is when you are experiencing a labor arrest in the late first stage of labor. In that case, assessing the fetal head position together with other clinical parameters may be helpful to understand if this woman has a good chance to progress, or if you have to consider a cesarean delivery in the first stage of labor. So basically, these are the two clinical moments where I think that ultrasound can make the difference.
Fantastic. And one final question from Anna in Canada. Thank you for a fantastic talk. Given the challenges when training MDs to implement this in clinical practice, and from a quality assurance perspective, have you developed an educational or implementation protocol that you could share with our assembled audience today, that they could start thinking about, start using? We would love to have anything you have, Tullio, and we can send that to the assembled crowd as well.
I will. Just to make things simpler, as you said, assessing the fetal head position is really straightforward for any obstetrician that can do assessment of fetal biometry or whatever is looking at with ultrasound. For the transperineal approach, I agree this can be more difficult, but there have been now some simulators that have been created that can give the practitioner the chance to learn how to measure the angle of progression or the head perineum distance on a phantom, in order to be less stressed whenever is needed to do it in the current practice to assess the fetal head station.
Thank you, Tullio. I think, Tullio, we're going to let you go because, oh, Mar, I'm so sorry.
Just a short comment. Tullio, brilliant talk as always. I just wanted to point out that we recently published a study where we proved that actually our never trained midwives were capable of achieving the same results and getting a nice and reproducible measurements after just training in 20 women each. So it's feasible, even, I believe, transperineal ultrasound, even for not expert obstetricians. So I encourage everyone to even share with their midwives.
And Tullio, I'd encourage you, I know you say it's simple and facile to train someone to check the position, but there are a lot of clinicians who may not do ultrasound every day or at all, and who have an ultrasound machine on the labor and delivery. Creating a short instruction leaflet or instruction video to say, this is how you identify the orbits, this is how, or whatever it is that you identify, that would tell them the position. I guarantee you would break barriers. We've got to think beyond our MFM community and think more about, the jobbing obstetrician on the floor, as you rightly say, when thinking about training. Prashant, please say hello.
Yeah, hi everyone. Good to see you all. Now, in India, again, I tell you, the use of ultrasound during labor is barely minimum. The moment, if we can, I would say we can tell them that, okay, that's how it is more important. And then we'll have a huge amount of data. In my institute, only we have 20,000 delivery every year. So the moment we start working on the same project, if they can, we can convince them that it is going to reduce the cesarean section rate or instrumental delivery. Of course, it's an issue because of the injury to the fetus and then outcome. And I completely agree with Joe that in India, again, still all about the litigations and an outcome in particular, when everyone is concerned about the outcome. Outcome has to be good. You can't have a baby going to a NICU just because we have an instrumental delivery. That's is less acceptable, and that's what one of the major issue in India. And if we can produce the data that, okay, it will reduce the NICU admission or the outcome is going to be better, then yeah, it can be we can have a good I would say percolating ultrasound in during labor in India.
I love numbers. There's 140 million babies born per year around the world. 25 million of them are born in India. Okay, the largest proportion of all births around the world. So when Prashant says something, we have to jump because actually, in terms of numerical differences that we make to people around the world, addressing single countries as large as India can have a major impact on global outcomes. So thank you, Prashant, for that really important message. Tullio, we're very grateful for you joining from your holidays. We're going to let you go. You are talking at the SMFM in Rome. What are you talking about at the SMFM in Rome?
I will challenge the three-tier system in the CTG interpretation from United States with a more physiological approach. I hope to engage the audience on that.
Fantastic. So we invite you all to come to the SMFM in Rome to hear Tullio, brilliant speaker, on a completely different subject of fetal heart rate interpretation during labor. Thank you very much, and go and enjoy your family and your holiday.
Thank you.
Right. Who's next? Is it Mar who's speaking next? I think Mar, you're speaking next. Mar Gil, a good friend and colleague who is a professor in Madrid, trained at the High-Risk Birthright Unit in the UK, and has a special interest in fetal development and non-invasive prenatal testing, twin pregnancy, but also preeclampsia, screening and prevention of preeclampsia. And that's what she's going to be talking to us about today. Mar, I asked Mar specifically to talk about issues around implementation. So we've seen the data, we've heard about the data, but how can we actually put these data that are so powerful and important into practice? Mar, really looking forward to hearing you speak today, and also, again, you will also be at our meeting in Rome, so double the fun for us.
So hello everyone, and thank you very much, Aris and Joy, for the invitation. I'll be discussing, and I believe we were recently presenting the very successful results from clinical implementation of first trimester screening for preeclampsia in over 20,000 pregnancies in Spain. And when preparing this webinar, I think we thought that it could be interesting to share all the lessons we've learned over the past few years with this beautiful audience. Have nothing to disclose, and there is always this argument whether when we are going to implement whatever strategy, this is going to work equally well in the adopted population. And for a screening system, when we construct the model, it's a mathematical model that will be based on a specific population with specific genetic conditions, healthcare conditions, even women's characteristics are specific from that area. Then we bring that model to a complete different population where all those things can differ, and the results may not be the same. And even if the characteristics are similar, we still don't get the same results. So somehow there is always a need of externally validate any screening model. And that's what we did in Spain, having trained in London for several years, participated in the ASPRE trial, came back to Spain 7 years ago, and together with brilliant doctors in Spain, we decided that before we would be introducing the first trimester screening of preeclampsia in Spain, that we were very much willing to do it, we would validate the algorithm and we'll make sure that we would be doing it in a proper way. And Joe is an expert in quality, and I hope he will also share some comments with us later. So we decided that we would be adopting the FMF triple test that combines maternal risk factors with mean arterial pressure, placental growth factor, and the pulsatility index in the uterine arteries. Why? Well, first, because of the high performance at 10% screen positive rate, the FMF triple test detects 90% of the early preeclampsias, those requiring delivery before 34 weeks, and about 82% of the preterm preeclampsias, as compared to traditional NICE guidelines that are widely used in Europe, which for the same screen positive rate only detect about 45% of those cases. If we move, and since we're in the SMFM Congress, to the ACO guidelines, yes, they will detect a similar percentage of women as the FMF algorithm, but at much higher screen positive rate of about 66%. So certainly that was not an option for us in Spain. How does the FMF algorithm work? And I am not going to go through it, but basically it assumes that if the pregnancy was going to last forever, every woman would develop preeclampsia at some point, and it's a matter of whether the delivery occurs before or after the development of the preeclampsia. So it's a competing event. So the basics are similar to those of the screening for Downs. We determine a prior risk based on maternal factors. We measure a set of biomarkers. We transform those biomarkers into MOMs, and all those things will modify that prior risk to estimate a posterior risk. It has several advantages. First, it gives a personalized risk. So it's not the same whether you are told that because you are 40, you are high risk, than when someone tells you, look, your risk is 1 in 2 for the patient, but also for the doctors. It estimates the risk of preeclampsia at any desired gestation. It means before 34 weeks, before 37, at term. It can easily be expanded to include additional biomarkers when they are developed and when they are described. And it takes into account the increasing effect of biomarkers with the severity of the disease. So it's not only, yes, you have an increased BMI or not, is how increased it is, it will increase the risk accordingly. Now, we know that for the FMF screening, we need to measure the blood pressure, we need to measure the uterine arteries, and we need to measure the placental growth factor. And yes, we needed to justify, we needed to choose the algorithm. As I said, we did the FMF algorithm, but there are some other algorithms available in Spain, and I am aware that they are widely used also, for example, in Latin America, which are those developed in Barcelona, that they can expand the analysis of PLGF before 10 weeks, but unfortunately, those at that gestational age, the discriminacy between abnormal and normal is not as good as later on. Then how to do this screening? We need to do all these things. Can we have all those results? In which way? And the options we thought, and each hospital, each center decided what was best for them, is to first take the blood sample at 10, in the case of the FMF screening at 11 weeks, and then to perform the ultrasounds a few days later. Typically, we were doing at 11 plus 3, 11 plus 6, and the patient was coming back 5 days later. Or we could do first the scan, take the blood on the same assessment, and then if we're lucky and they can process the sample quickly, the patient can have everything same morning, or if we are not, which is our case, none of the centers could do that, the one step. So we were calling the patient the following day to provide her with the results. And I bring this slide here just to show you that despite it is actually possible to use placental growth factor at 10 weeks, the performance of the screening in that case is poor. So we conducted this large study to examine the effect of routine clinical implementation of this first trimester prediction and prevention screening for preterm preeclampsia in our country. We were 8 large maternity units across all Spain, and we designed a 2-phase study. The first phase would be a non-intervention screening at 11 to 13 weeks, which means we were collecting prospectively all the data from screening, but we were not disclosing the risks, we didn't know them, and we were not taking any action. So we were not giving aspirin on those bases. We were lucky. The aspirin was still in the process of being publishing or just published, so guidelines have not changed. And then a second phase where we were screening and we were giving aspirin to the high-risk group. And we just wanted to compare the incidence of preterm preeclampsia between the non-intervention and the intervention phases. From the first phase, we screened over 10,000 women, and we basically wanted to validate the FMF algorithm, to compare also with the others and ensure that there were no significant differences among them. And yes, we showed that the FMF algorithm was able to detect above 80% of the early preeclampsias and about 73% of the preterm preeclampsias, absolutely similar to the FMF results, so successful validation. And on the right side, you have the calibration plots, which is another way of looking at the results, where we basically analyze whether the risk, the individual risk that we are giving to the patient corresponds to what happens next. Example, if I have 2 patients with a risk of 1 in 2, one of them has preeclampsia and the other one will not have it. And same, I have 100 patients with a risk of 1 in 100, one would develop preeclampsia and the other 99 wouldn't. So that means a perfect calibration. And that's basically what we observed. So having demonstrated that the algorithm worked, we went on to the intervention phase. But during that cohort, we conducted and developed a prospective, easy quality control system. What for? Well, we needed to know that we were doing the things right before saying that the algorithm didn't work. So we needed to assess the performance of the biomarkers separately and the screening. So the first biomarker, mean arterial pressure, uterine artery pulsatility index, placental growth factor. And as I said, the performance of the algorithm through calibration plots. So basically, we are constantly calculating multiples of the median. Multiple of the median is simple, it's the value of the biomarker divided by the median of in the population, but it needs to be adjusted by the maternal and pregnancy characteristics as I list there. What if that is wrong? What if I collect a wrong clinical history? Or what if I am systematically underestimating any value? Well, let's look at the blue line that represents PLGF moms. So if I'm systematically underestimating the mom below 1, I will be systematically increasing the risk that I am giving, the estimation of risk that I'm giving to that patient. And the opposite happens to uterine artery PI or MAP. The first time we run the quality control, we must not be upset if we find something like this. You can see that well, basically there is a range where one mom is what we should get, and there is a range in several tonalities of pink where our medians should be. And well, that was the first assessment, and they were not good. But then we don't need to be demoralized. We don't have to be demoralized. We need to look through it and investigate and recognize what the problem is. I'm going to give you 2 examples. in my hospital where I was working, we were systematically increasing the blood pressure just because we were rushing to bring the patient inside the clinic. Then we calibrated the devices. We let the patient rest for a couple of minutes before after she arrived, and then the medians were back to normal. That's the same that you can see in the graph below, where it's a cumulative error. So we were systematically increasing, accumulating errors, and then we overcorrected, and then we went back to normal. For example, my colleague Nuria in Coruña, they did the opposite. They were taking systematically the lowest of 3 measurements. And then once they reviewed the protocol and they started to collect the first 2 measurements in each arm, then the moms went to normal. We also need to look at how each of us are performing. We don't need to be upset if we are told that our uterines are too low or too high. We just need to get a feedback and to take an action, either to be retrained, either to practice, either to look at the automatic trace of our machine, because it may happen that the MI center is performing well, but the different operators are not doing the things as well as we can see in the medians that are represented by the pink arrows. And finally, and this has been very common problem in all the centers that I've been not only participating in the study, but I've been speaking with, the PLGF was systematically low. That's because it's a quite unstable reagent, and that only needs to be center-based corrected. So it's a correction factor, as we have always been doing for FreeVita ECG and PAPE, and that's a teamwork with our laboratory. Now, did it work, our implementation? So those are the basis of our study. We knew that we would be detecting 90% of the early preeclampsias, 75% of the preterm preeclampsias, and we would be preventing 82% of the early preeclampsias and 62% of the preterm preeclampsias, according to the ASPRE study, by providing aspirin. That means, and there are a lot of numbers here. I don't want you to get lost, but if I take a population of 10,000 pregnancies, I should find about 30 cases of early preeclampsia with an incidence of 0.3%, that's ours, and 70 cases of preterm preeclampsia due to an incidence of 0.7%. If we detect then the percentage that I just mentioned, we should be detecting 27 of those 30 and 53 of those 70. And now, almost last, we should be preventing 80% of those 27 cases, which is 22 of the 27 cases, and 60% of the 53. That means that we should be preventing 32 of the detected 53. To sum up, we should be predicting and preventing 73% of the cases of early preeclampsia, a reduction of 73% in the early preeclampsia, and 46% of the preterm preeclampsia. And we wanted to demonstrate that. So we conducted the second cohort where it was routine clinical implementation. This was not within a research setting anymore. Patients were consenting for screening, but there was not research involved in that, and that screening. We, again, screened over 10,000 pregnancies, absolutely similar characteristics, absolutely similar risk profile, as I am representing on the histogram, in the histogram on the right. And these were our results. From the first phase, the so-called PREVAL study, we fixed the screen positive rate at 10%, and we estimated the risk cutoff, which was 1 in 90. For a practical point of view, we decided that we would use the 1 in 100 as in the ASPRE, because it's easier to remember, it's a little bit more logical. And in the second cohort, the decreased cohort, we estimated that yielded an 11% screen positive rate, exactly as happened in the ASPRE study. And as I said before, in both phases, we were continuously checking and controlling quality. And here are the results in terms of efficacy of the aspirin prophylaxis. In the first phase, PREVAL, we had 31 cases of early preeclampsia, and 72 cases of preterm preeclampsia. And after implementing the screening, we reduced that 31 to 8. So we prevented 23 of the previous 31. And we only had 32 cases that required, of preeclampsia cases that required delivery before 37 weeks. So we prevented 34 of the previous 71. And I'm bringing that scheme that I showed you before just to demonstrate that those were our predictions. Yes, we reduced the incidence of early preeclampsia by 74% and preterm preeclampsia by almost half. So I believe I want to encourage you that it's feasible, and to do a screening, we just need to set up our clinics. So what have we learned? That we can implement it, and we need to adapt the logistics to each center. What works for me does not necessarily need to work for someone else in any other different setting. Depends if the patients live far, if they can come, several aspects to take into account. There is a need for continuous quality control and monitoring, and retraining and looking at ourselves is not uncommon, and we don't have to take it in a personal way. It's just what doctors have to do to improve. We need to continuously monitor the screen positive rate to learn that we are not screening too many people positively or too little, and we need to adjust our moms. We need to make them be one medium, and that's a joint effort together with our laboratory. And we need to adjust the cutoff. Thank you very much for your attention.
Thank you very much. Thank you so much for giving us a beautiful overview of some of the practical challenges of implementing this really powerful prediction and prevention pair. And you know, you've done a fantastic job in this sort of multi-center approach, demonstrating some of the ways of monitoring uterine Dopplers, monitoring PLGF, monitoring blood pressure. And a question just before I go to the panel: is this something that, you know, QSUM, for example, and all of these things, is this something that is can be shared with other people who are trying to set up similar quality control programs? Some of those algorithms are pretty straightforward, but they're not completely uncomplicated to write. I don't know if that's something that can be shared with other people in other settings who may want to set up similar kind of programs.
Thank you for the question. Well, fortunately for all of us, I believe that Professor Nicolaides is in the process of releasing the FMF software, and that will be giving us automatically all these graphs and all these figures that I've been showing to you. So I think in that respect, if we are using FMF algorithm, we will be safe. Otherwise, as you said, it's not easy to write them at the first time, but they're publicly available. It's just a bit of effort to write them.
Thank you very much. Prashant.
And now, the whole concept of Aspirate trial is to start aspirin to where the patients you find that she has got a higher risk for preterm preeclampsia. Am I right? But
yep.
If you go to the Fetal Medicine Foundation right now, if you see the risk calculator there to predict that preeclampsia risk, you find only one algorithm, preterm preeclampsia before 37 weeks, and the preeclampsia more than 37 weeks. Here, it does not show. Usually what we consider that when the preeclampsia sets in before 32 weeks of the gestation, we consider aspirin is going to be the best. But the Fetal Medicine Foundation right now also shows only one cutoff, 37, more or less. Any reason behind this?
Thank you. Well, the Aspirate trial, the only significant result, because it was the main objective, was the reduction before 37 weeks. Although before 34 and before 32, the p-value was below 0.05, because it was a secondary analysis. It was set up to an confidence interval of 99% instead of 95%. To summarize, you need to give aspirin to women at high risk of preterm preeclampsia before 37, even if it has been proven that it will work also for early and more severe cases. I believe the right thing is just to display the preterm birth, the preterm preeclampsia risk.
So, but in the present day,
Mar, sorry, please.
In the present day scenario, if the baby is delivered at 36 week or 35 week or 37 week, are we worried? Practically no. If the baby is delivered by 30, 31 or 32 week because of the preeclampsia, that's where we are worried because for the intact survival. So the moment these trial or whatever aspirin, if it is going to prevent that preterm preeclampsia before 32 week or before 33 week, it will have a huge impact on overall survival of those babies. So rather than cutting it off at 37 week, if you reduce it to say 32 or 33 week, and if you reanalyze your data, it will give us far more better results for our day-to-day clinical practice, and it will seriously, because we are also worried about early severe preeclampsia.
But the risk factors, the risk factors are the same, aren't they, Prashant? So
Yes.
It's mean arterial pressure, uterine artery Doppler, and PLGF, and then the risk calculation is the same actually for each, regardless of the cutoff. What is different is the prevalence of the disease. Right. So higher prevalence at less than 37 weeks, lower prevalence at less than 34 weeks, even less at less than 32. When you have the woman who has a high risk result, you don't know in advance whether she's going to develop the disease at 32, 34, or 37 weeks. And therefore, Mar's point is that if you have a woman who is at high risk, giving aspirin is the right thing to do. And then the question is, well, what is high risk? And that is where your question is, in a way, more relevant. Do you start aspirin at a cutoff of 1 in 100 or 1 in 90, 1 in 150? And that is where there are slight differences in opinion. From the sort of trialist perspective, the answer is really simple. You know, the higher the risk, the lower the number needed to treat to prevent one case of preeclampsia, and the lower the risk cutoff, the higher the number of women you need to treat to prevent one case of preeclampsia. But, you know, given the relative safety of aspirin and the relative severity of early onset preeclampsia, to me, having a slightly lower cutoff is not relevant, is not so important. I don't know if I interpret your question correctly, but remember that the risk calculation is the same. It's the gestational age changes only the prevalence of the disease.
Yeah.
So Joey, welcome, and I hope you can give us a few words.
I'm grateful to Aris and Joey for highlighting the upcoming SMFM global meeting in Rome. Joey has done so much work on this and the whole committee, so we're very, very excited to be there. So as you probably all are aware, cell-free DNA testing has revolutionized prenatal screening for common autosomal trisomies. Recent data shows very high detection rates for trisomy 21, 18, and 13, although the positive predictive values vary based on the specific trisomy involved, as well as maternal age as well and history. Also important, the positive predictive value is the presence or absence of fetal defects on ultrasound. And due to false positives and false negatives, as well as the specific chromosomes involved, ultrasound really plays a key role in determining which is the most appropriate diagnostic test to perform after an abnormal NIPT result. And I do realize that screening with cell-free DNA varies across the globe. In the US, it's extremely common, but in other countries, obviously not as common as some other tests. So I really don't have any relevant disclosures to this talk other than I do like performing needle-guided procedures. So just for some history, it was back in 2011 that cell-free DNA became commercially available in the US for the common autosomal trisomies 13, 18, 21, as well as the sex chromosomal abnormalities. About a year later, the American College of OBGYN and the Society for Maternal-Fetal Medicine did recommend cell-free DNA screening be offered for those patients at higher risk for these trisomies. So those of advanced maternal age or with positive biochemical and/or nuchal translucency screening. It wasn't until 2020 that ACOG recommended that all patients be offered genetic screening, including cell-free DNA, as well as diagnostic testing. And then recently, there are many labs that offer, in addition to screening for the common trisomies, screening for microdeletions, as well as the rare autosomal trisomies. So one question is, should ultrasound be performed prior to screening using cell-free DNA? And should cell-free DNA screening be offered at the 11 to 13 plus week ultrasound in combination? So do it at the same time. For a little bit of background, during pregnancy, the maternal blood contains both maternal as well as placental cell-free DNA. The maternal amount is much higher than the placental amount, and it's this platform where we can use the placental DNA to screen for the autosomal trisomies. So the while this screening has been around for a long time, we do know that there's some little background in terms of the mechanism of action for the screening. So the fetus and the placenta originate from one single fertilized egg, and the inner cell mass forms the fetus, and the outer cell mass, the placenta and the membranes. We do know that placental cells undergo programmed cell death or apoptosis. And when that occurs, the DNA gets released into broken fragments into the maternal circulation. What I just showed you is the placental cell-free DNA. And while in most of the time, the placental DNA is genetically identical to the fetal DNA, there may be a difference that are sources of discordant cell-free DNA results. So the accuracy of cell-free DNA screening is dependent on the proportion of cell-free DNA. We know that cell-free DNA is present as early as 5 weeks, but it's really not in significant amounts until you hit about 10 weeks. Some of the limitations of this test are the false positive rates, false negative rates, multiple gestations. There's recent data that shows that it's highly accurate with twins, but there's very little data on higher order multiples. And in the case where an ultrasound is performed before cell-free DNA is done, and there's a chromosome, there's a fetal significant fetal anomaly detected, the screening is really not recommended. It's more recommended to go straight to a diagnostic test. This was a study that looked at the performance of an ultrasound prior to cell-free DNA screening to see whether or not the ultrasound led to a change in the management. So they had over 6,000 patients who underwent an ultrasound prior to cell-free DNA screening. And they found that in about 10% of cases, it did lead to a change in the management. They found in about 4% of the time, the gestational age was actually less than 10 weeks. In about 3%, they diagnosed a miscarriage, 0.7% a vanished twin. In about 2%, fetal edema was diagnosed, and in 0.3%, fetal structural anomalies. And I think as first trimester detailed ultrasound is becoming more and more commonplace, this becomes quite important. So overall, detection rates are very high, particularly for trisomy 21 and 18, 99 to 97%. Trisomy 13 and the sex chromosomes, a little lower detection rate, about 85 to 87%. And the good news is the false positive rate is quite low for all of these. There is a recent meta-analysis that was published by Rose and others in 2022, and they actually found detection rates for trisomy 21 and 18 to be 99%, and as opposed to the previous slide, trisomy 13 had 100% detection rate. False positive rates in this case were even lower at 0.04 to 0.07%. And positive predictive values did vary based on the chromosome involved, so higher for trisomy 21 and lower for trisomy 13. Of course, these positive predictive values will vary based on maternal age, and again, findings on ultrasound. As I mentioned, many labs, certainly in the US, have expanded the option beyond common aneuploidies and sex chromosomal abnormalities. And so many now have the option to include screening for chromosomal microdeletions, as well as the rare autosomal trisomies. In a systematic review, they looked at 182 cases of false positive cell-free DNA screening results, and about a third of them were due to confined placental mosaicism, which I'm going to tend to focus more on. For false negatives, they were mainly due to true fetal mosaicism. So again, causes of false positive cell-free DNA results, confined placental mosaicism is quite important and will influence the type of diagnostic test that should be performed. Other causes are vanished twin syndrome, maternal mosaicism, uterine fibroids, maternal malignancies, as well as low fetal fraction. And we tend to see low fetal fraction more commonly in the obese population, as well as patients that are on low molecular weight heparin. So what do you do when you have a positive cell-free DNA screen? So first step would be genetic counseling. I think it's very important for patients to understand what this means and what the options are. A detailed ultrasound evaluation is very important, as we'll discuss, to determine what is the best test to then do. Offer the diagnostic testing, and we'll go into a little bit more detail. This is based on which chromosome is involved, as well as the ultrasound exam. And then in some cases, a workup for maternal genetic disorders if the fetal testing is normal. So in terms of options for diagnostic testing, of course, there's chorionic villus sampling or amniocentesis. The real benefit of CVS is that it provides a much earlier answer, which is really important to patients who tend to be quite anxious when they get a high-risk result on the cell-free DNA test. However, it may not always be the appropriate test given the potential for confined placental mosaicism. So let's focus on CPM, as this is the most widely recognized cause of false positive NIPT results. So to determine the most appropriate follow-up test, and understanding of confined placental mosaicism becomes really important. In early development, the embryo starts off as single cells and continues to divide and can divide incorrectly really at any stage. And when that happens, it has an impact on the cell-free DNA results. When abnormal cells are present in the inner cell mass and the trophectoderm, it would lead to true mosaicism. When the abnormal cells are found in the trophectoderm, but not in the fetus, it leads to confined placental mosaicism. In terms of mechanisms, confined placental mosaicism can arise as a result of post-zygotic error through non-disjunction in a diploid conceptus. But it can also arise by a trisomic rescue mechanism in which the conceptus starts off as a trisomy, but loses one abnormal chromosome or one extra chromosome, what we call trisomic rescue, in an attempt to become more normalized. And that would result in a diploid cell line within the fetus, but it can continue to have trisomic cells in the placenta. So this diagram shows a blastocyst at the top at around day 5 of embryonic development. And you can see two cell types that are defined at this early stage, the trophectoderm and the inner cell mass. The extraembryonic trophectoderm develops into two tissues of the fetal part of the placenta, the syncytial trophoblast and the cytotrophoblast. And short-term cultured villi studies examine that cytotrophoblast. The inner cell mass will develop into the epiblast, which eventually forms the fetus, and the hypoblast, which eventually forms the mesenchymal core. The long-term culture villi studies examine the mesenchymal core. And because they're of the same origin, that is the inner cell mass, the long-term cultured villi is a better reflection of the fetus than the short-term cultured villi. And this is really important to understand as we look at the different types of CPM that we see. So combined placental mosaicism is divided into types 1, 2, or 3, depending on the cellular lines that are involved in the aneuploidy. So you can see that with type 1 CPM, it describes aneuploidy that's exclusively present in the cytotrophoblast, which is what we see with cell-free DNA. While type 2 involves aneuploidy exclusively in the mesenchymal layer, and type 3 involves aneuploidy in both the cytotrophoblast as well as the mesenchyme. You can see with type 1 that it would lead to a high-risk result and usually results from mitotic errors. With type 2, because it is from cells that are cultured in the mesenchyme, which more likely reflects the fetal chromosomes, it's more likely to yield a low-risk result. And with type 3, where it comes from both the cytotrophoblast and the mesenchyme, it's again more likely to result from errors during meiosis and would also lead to a high risk result. In terms of the common aneuploidies, trisomy 13, 18, 21, the positive predictive value again varies based on maternal age as well as the prevalence of the aneuploidy involved. So you can see for trisomy 21, between 91 to 99%, trisomy 18, 66 to 92%, and for 13, 43 to 71%. In a study analyzing over 52,000 CVS samples that included both direct and long-term cultures of chorionic villi, close to 1,000 had evidence of mosaicism in the direct analysis of CVS, which corresponds to the cytotrophoblast, which is what's analyzed in the cell-free DNA screening. Combined placental mosaicism was apparent in 22% of cases of trisomy 22 cases of trisomy 13, 4% of trisomy 18, and 44% of trisomy 21. If a mosaic was found on the CVS, the probability of an abnormal amniocentesis was 4% in trisomy 13, 14% in trisomy 18, and 44% in trisomy 21. Given the high rate of CPM for trisomy 13, the positive NIPT result is much more likely to represent a false positive due to CPM compared to trisomy 18 and 21. So it's reasonable to counsel patients that amniocentesis is more accurate in these cases. However, given the high rate of structural anomalies in fetuses with trisomy 13, ultrasound can be very helpful in patient counseling. So in this case where there was a high risk for trisomy 13, when you see this finding on an early ultrasound, you're more likely to say, well, this is a real trisomy 13 and go straight to a CVS. Well, what about monosomy X? The positive predictive value of monosomy X is not that high at 25%. There's a lot of different mechanisms for this: confined placental mosaicism, certainly, maternal mosaicism, vanished twins, and then the spontaneous age-related loss of maternal chromosome X. When an invasive test is performed, if that test is normal and then a maternal test is considered, an abnormal maternal karyotype does not actually rule out a fetal genetic condition, so you really do need to define that. Also, 45X often has abnormal ultrasound findings, but mosaic 45X usually does not. If the first trimester ultrasound has a large nuchal translucency or a cystic hygroma, then certainly CVS would be the recommended diagnostic test. So if you do an ultrasound in that first trimester and you get this cystic hygroma that you see in 2D or in 3D ultrasound, the correct test would be going to CVS. So again, several labs are now offering testing for rare autosomal trisomies. And there's unfortunately little guidance to patients as well as clinicians for how to interpret or manage these results. For the true rare autosomal trisomies, they're really not compatible with life. So only cases of fetal mosaicism will survive. And unfortunately, it's difficult to counsel these patients because there's a very variable presentation from being near normal to being severely affected. Essentially, all will have a mosaic result, so amniocentesis for confirmation of CPM versus true fetal mosaicism would be the best step forward. For any rare autosomal trisomy on cell-free DNA, with the normal first trimester ultrasound, vast majority will be due to confined placental mosaicism, because the ones that are real will typically have ultrasound findings. And then some exceptions for considering testing for rare autosomal trisomies would be a testing for those chromosomes with imprinted genes. So 1.5% of cell-free DNA results with rare autosomal trisomies will represent true fetal mosaic cases and actually survive to the second trimester. About a third of them will have abnormal ultrasound findings. Again, the rationale for testing for the rare autosomal trisomies, even if it's not a true fetal mosaic, is to identify cases of uniparental disomy. And these are the chromosomes 6, 7, 11, 14, 15, and 20, which have imprinted genes on them. I mentioned trisomic rescue. So in trisomic rescue, where it starts off, the conceptus starts off as a trisomy, the loss of one chromosome is quite random. So you can lose one and end up with 2 maternal chromosomes or 2 paternal chromosomes. And for these chromosomes with imprinted genes, depending on whether it's maternal or paternal UPD, it's associated with various different genetic syndromes. The other rationale for testing for these rare autosomal trisomies would be to identify pregnancies with CPM that are at risk for placental dysfunction. So when to test for uniparental disomy? If you have mosaicism of one of the imprinted chromosomes in a CVS or amniocentesis sample. If you have an abnormal CVS, but a normal amniocentesis, again, with one of the chromosomes with imprinted genes. We're seeing more and more transfers of some mosaic embryos with our REI colleagues with aneuploidy that may involve one of the imprinted genes. And ultrasound can be helpful. Again, with Beckwith-Wiedemann syndrome, you may see omphalocele, macroglossia, visceromegaly, later on macrosomia, and enlarged adrenals. And Russell-Silver syndrome, we know, can be associated very commonly with fetal growth restriction. So recommend amniocentesis or CVS, although given the risk of CPM, amniocentesis may be needed to confirm diagnosis if CVS is chosen. If the amniocentesis is normal, then the patient should be offered methylation studies to test for UPD. And then there's also the case for multiple aneuploidies that may be seen on cell-free DNA screening. Most of the time with multiple aneuploidies, you're going to have an abnormal appearing fetus. If you have a normal ultrasound, then it's unlikely in the setting of multiple aneuploidies to have it be true, a true multiple aneuploidies. It does raise concern for maternal malignancy, and so taking a history, doing a physical exam, sending labs and potential imaging would be important. So how can an ultrasound help with positive NIPT results? So again, with trisomy, if the NIPT shows high risk for trisomy 13 and you have a finding like this, or trisomy 18, where you may see multiple anomalies, including omphalocele, micrognathia, clenched hands, trisomy 21, where you might see an abnormal fetal heart early in the pregnancy, or monosomy X, where you will have a very enlarged nuchal translucency. In those cases, the choice of the CVS makes the most sense. So just to review and summarize in terms of the suggestive management after an abnormal cell-free DNA result, if the chromosome involved is trisomy 18 or 21, which is a common aneuploidy with a low rate of CPM, CVS may be offered, especially if there's an abnormal ultrasound. Although if there's mosaicism on the CVS, and amniocentesis would be the next step. With trisomy 13, again, a common aneuploidy, there's a much higher rate of CPM. If the first trimester ultrasound is normal, then an amniocentesis would make the most sense. However, if the ultrasound is abnormal, CVS would be the preferable choice of test. If there's mosaicism, again, on the CVS, an amniocentesis would be needed for clarification. For the rare autosomal trisomies, again, if there's a normal first trimester ultrasound, amniocentesis would make the most sense. However, if there's an abnormal findings on first trimester ultrasound, CVS would be the next, the preferred test to do. However, it's important to keep in mind with these rare autosomal trisomies, there's a higher rate of placental dysfunction, especially if it involves trisomy 16. So an ultrasound for growth in the third trimester would be highly recommended. And then for the rare autosomal trisomies with imprinted genes, CVS would be the recommended test. And if it's abnormal, then an amniocentesis. If the fetus is found to be unaffected, methylation studies should be certainly considered to look for UPD. For monosomy X, which is again a common aneuploidy, there's a high rate of CPM. If the ultrasound is normal, the next step would be to proceed to amniocentesis. However, if it's abnormal, then CVS is absolutely the reasonable approach. If the fetus is unaffected, then consider maternal karyotype for mosaic Turner syndrome. If there's a finding of multiple aneuploidies, there's a higher risk of maternal malignancy. So again, with a normal first trimester ultrasound, amniocentesis would be preferable. If it's abnormal, CVS. And again, if the fetus is found to be unaffected, consider workup for maternal malignancy. So I want to thank you so much for allowing me to speak today, and just such an honor to be with this incredible group. I'll stop sharing.
Thank you so much, Joanne. Well, you packed so much information into that presentation. Just going back to your, so it was brilliant. Thank you for that. Just going back to your original title, amniocentesis or CVS for after a cell-free DNA result, which you summarized brilliantly in those 2 slides. If I just confine myself to what the most common ones are. So trisomy 21, trisomy 18, even if the baby looks normal on the scan, you would be happy to go ahead with a CVS. This is not universally accepted, by the way, but you know, in your hands, this is what and what Mary Norton in her article says, because the rate of CPM is low. But for trisomy 13 and Turner's, you would suggest that if the scan looks normal, to wait until an amniocentesis.
Yes, I think because, you know, you're really looking at which chromosomes have a much higher rate of CPM, like with trisomy 13. Certainly, I mean, I just had a patient, I think yesterday, who had cell-free DNA at high risk for monosomy X, and she couldn't wait for the amniocentesis, even though I recommended it. And I said, well, you know, the cell-free DNA is the same, you know, coming off of the placenta, right? So we're testing the placenta with CVS. Really makes more sense, but she was too uptight. And I said, well, understand there's a high chance that you're going to need to do a amniocentesis anyway. I mean, I'm in New York, so the level of, you know, wanting things done yesterday, I think is you know, comes into play. And you know, everybody's different. This patient already was asking, should she schedule her visit with family planning to terminate the pregnancy? I'm like, the ultrasound is normal, you know, I think it's going to be CPM, but you know, it depends on the patient population and patient preferences as well. So you can make a recommendation, but sometimes you go.
We get around that problem in the UK by not testing the sex chromosome aneuploidies. Generally speaking, not recommended within our National Health Service for the reasons that you outlined, the difficulties the high false positive rate, the difficulties in decision-making around invasive testing, but also the differential phenotypes and the fact that the majority of Turner's fetuses, if they have no increased nuptial translucency, are not considered at risk. Now, trisomy 13 obviously is a really good case, because in trisomy 13 you would really expect an ultrasound scan to show something, right? If you did a detailed ultrasound scan and if the scan looks completely normal, you would have thought that it's more likely that that's a false positive NIPT. But what's the situation with trisomy 18? How often are we seeing a completely normal scan with trisomy 18?
I mean, I think the majority will have an abnormal result with trisomy 18, although certainly they're having cases of normal first trimester ultrasound. Again, I had a patient not long ago who she actually was twins and did a CVS, and one came back. She had the CVS someplace, another hospital in New York, and came back with trisomy 18, and the physician that did the CVS broke his hand before scheduled selective termination, because she was scheduled for selective termination. So she was referred to me, and I scanned her. I'm like, this fetus looks too normal. How can it, like, can't be, it shouldn't be trisomy 18, because usually you will see something, right? 99, percent will have a heart defect. And as we're getting so much better at first trimester ultrasound, I think we're seeing these abnormalities much earlier. So we repeated the CVS, we found like one cell, did an amniocentesis, found totally normal, and she ended up having 2 normal fetuses. And if it weren't for him breaking his hand, the result would have been different. So I do think, this is why I think the first trimester ultrasound is really incredibly important in terms of our workup and what the correct testing will be. I know some ambiguous genitalia or even some disorders of sexual development is pretty rare, but it is some of the times that having cell-free DNA result for sex chromosomes is very helpful, because if they tell you, on my cell-free DNA test, it's a male, and then you scan them and it looks female, those are times that will be helpful. I mean, it's of course not going to be necessarily cost effective in the UK, certainly that wouldn't fly, but it can be helpful.
Okay, now we're lucky to have Mar on the webinar, who not only has done this fantastic work on preeclampsia, but has done a huge amount of work on NIPT testing and also synthesizing the data from all these different studies. Mar, in your practice, when it comes to managing a positive cell-free DNA test, do you follow this sort of similar algorithm, or have you got differences? And if that is the case, how does that look?
Yeah, thank you. It's pretty similar, but it's the same point, and I think we've been discussing this every December in London. If the first trimester scan looks normal and there is a positive result for trisomy 18, we we recommend amniocentesis. Despite the rate of placental confined narcissism is 4%, it's still 4%. And I believe we are really good in first trimester scan nowadays. We have amazing machines, and if the scan looks normal, our recommendation, our practice in Spain is to postpone and to recommend amniocentesis. But for trisomy 21, yes, we do for CVS.
It's a difficult decision, isn't it? Because you've got the mother sitting on an abnormal NIPT result, and you're having to try and convince her to hang in there for 4 weeks, and then another week of getting the results back 5 weeks. It's difficult. So I agree with you that a very normal imaging result can lead to a degree of reassurance, and then it depends, who is going to be doing that imaging. Probably no one better in the world to do that imaging than someone like Prashant, who's such an expert at first trimester anomaly screening. So I don't know, Prashant, in your experience, given your level of expertise, is that something that's acceptable to you women? Do the women push for an early test, or are they sufficiently reassured by a normal ultrasound scan in the positive trisomy 18 scenario on an IPT to postpone and come for an amniocentesis?
No, they will prefer early evaluation. Unless the ultrasound is normal, we will go for early CVS, and in some cases, especially with the monosomy X, yes, I do believe we will do it a little later.
Thank you so much. Well, listen, it's been a fantastic webinar. We've gone from, labor backwards to the first trimester. There's a whole bunch of questions still online. I don't think we have time to go through all of them because we're up against the clock. In fact, we're over time. And so I'd like to really thank Joanne. Oh, Elena, you have your hand up. I'm so sorry.
Hi, thank you very much for this very clear and thorough presentation, Joanne. I would like to ask you and to all panelists, how are we labeling a soft marker in the context of a high risk NIPT for trisomy? I mean, it is likely that we will detect a major abnormality in case of a true positive trisomy 13 or trisomy 18. But what if we have a high risk NIPT for these two common aneuploidies and we have just a soft marker on the ultrasound? Would you offer a CBS or would you go for an amniocentesis?
I mean, for me, it becomes with a high risk result very different. So with a low risk result, we ignore the soft markers pretty much. But with a high risk result, I think anything that's suggestive of that goes along with the chromosomal abnormality, I think would suggest doing CBS.
I think it's a great question because all the literature has looked at it the other way. Nobody's really looked at it with the way you asked that question. But I think that when you think about, I guess, what are the soft markers we might reliably see in the first trimester, I think with an high-risk NIPT and what you're visualizing there, you really have to wonder how soft are those markers?
Yeah. Thank you. Thank you very much.
Joey, I'm going to give you the last word to re-invite everyone who's here to our meeting in Rome, and maybe just remind us of the website that people might want to join. All the speakers who we've had today, Tullio, Mar, Joanne, who are fantastic speakers, are all speaking also at the meeting in Rome. So it was to give people a little bit of a flavor of the sort of discussion, the sort of quality of presentations that you might expect there, which is fantastic. Plus much more that Joey talked about. So Joey, do you want to quickly summarize?
Sure. Well, and again, thank you, Aris, for the invitation to help co-host this and put it together with the Scan Academy and this opportunity for the SMFM. So again, our meeting is in Rome. It is in a fantastic setting in Rome at a music auditorium where every performer wants to come and sing. From people from Pavarotti to Sting have performed in this music hall, and a very unique setting. It is September 25th through September 28th. We have a day of pre-Congress courses and then the scientific presentations and invited talks that Thursday through Saturday morning. It will conclude at 1300 on Saturday, so people will have time to enjoy Rome and Italy and wherever else they may want to travel to. And you can get more information at smfm.org. It is featured on the website, and you can click the links and it will take you to information about the Global Congress. So thanks again, and I hope to meet and see some of you there in Rome.
Fantastic. Joey, thank you, and thanks to all the speakers. Bye,
Thank you.
everyone.
Thank you. Bye.
Thanks, Ars.